Hi everyone, thanks for listening to my presentations. Today I'll be talking about Leptomeningeal Neoplastic Meningitis. That may sound strange, right? No problem, let's go. Pathogenesis is essentially that the brain and spinal cord are surrounded by three membranes: Dura matter, arachnoid, and Pia matter. The arachnoid and Pia matter combined forms the leptomeninges. The cerebrospinal fluid, arteries, and tumor cells are found in subarachnoid space, sandwiched between arachnoid and pia mater. Still on pathogenesis, cells can enter the cerebrospinal fluid hematogenously, or through brain parenchyma direct extension, or choroid plexus, vertebral, subdural, epidural, retrograde invasion along central nervous system, or through primary tumor of meninges, example lymphoma, melanoma, or sarcomas. This is a rare condition. It's also known as leptomeningeal metastases. It is secondary to cancer, and in 46% of all patients with advanced stage cancer, that is, those with metastasis. It is less diagnosed in real life compared to larger asymptomatic and undiagnosed cases. But the diagnosis is higher at post-mortem or autopsy. The metastases to the central nervous system are commonly from the breast cancer, the lungs, melanoma, gastrointestinal tract, coexisting brain metastases. Improved treatment of cancers can actually increase the depth of leptomeningeal metastases, particularly in those who have undergone surgical resection of a brain metastasis. Clinical features or symptoms could take days to weeks, and the symptoms would depend on the site affected in the central nervous system. Could be headache, nausea or vomiting, leg weakness, cerebral dysfunction, altered level of consciousness, dizziness if there is associated hydrocephalus with increased intracranial pressure, papilloedema, meningeal irritation that will present with neck stiffness, neck pain, positive Kenny sign, and positive Brzezinski sign. If encephalopathy has occurred, we'll be dealing with confusion, forgetfulness, disorientation, lethargy, and personality changes. If there are craniopathies, we might be faced with diplopia, facial pain, facial weakness, sensorineural deafness, dysarthria, dysphagia, or hoarseness. If cerebral dysfunction are certain, there may be gait anomaly, difficulty walking, and dizziness. In case of radiculopathy, we'll be having radicular pain, numbness, and muscle weakness. There is a possibility of caudal equina syndrome, and I have published a separate presentation on caudal equina syndrome. So it would be nice if you can check my channel for detailed information as per caudal equina syndrome. Other clinical features could include seizures, lightheadedness, syncope, hemiparesis, aphasia, and visual field defects. when the pituitary gland or pituitary stalk is invaded, might be dealing with pan-hypopituitarism, might be faced with central diabetes insipidus. How do we make the diagnosis? Diagnosis will start from thorough history and a thorough physical examination. Magnetic resonance imaging of the brain and spinal cord will be helpful. We can have CT scan done, and then we can have lumbar puncture done, get cerebrospinal fluid for analysis. And what are we looking for? We're looking for circulating tumor cells, opening pressure to rule out increased intracranial pressure, and rule out infection with cerebrospinal fluid when we have the level of protein, glucose, polymorphonuclear cells, and we test for fungi. Differential diagnosis here could include metastasis to the brain itself, viral meningitis, TB meningitis, Lyme disease, cryptococcus, sarcoidosis, Wegener's granulomatosis, vasculitis, and Bell's palsy. The tumor markers here will be beta-2 microglobulin, CEA, that is carcinoembryonic antigen, CA125, that is cancer antigen 125, IgM, prostate-specific antigen, and 5-hydroxyindoacetic acid. Now, the treatment. First thing first, we have to go by ABC, that is A for the airway. And that will take us to checking the mouth or buccal cavity, the nostrils, the ears, for patency, then any bleeding, any secretion, and with suction as is appropriate. The P is for breathing. By this time, we want to know what the O2 side is all about, what the value of O2 side is, any central cyanosis, any peripheral cyanosis, what's the respiratory rate. And then we're going to check for any scars, obvious deformity, and then palpate for tracheal deviation or not, and percussion for dullness or upper resonance. We have to auscultate for the breath sounds, and if pick anything strange, we document that. The chest, is it moving with the abdomen? We document all this. Then for the C, we want to know what the BP is right now, what the heart rate is, and features of dehydration, dry lips, sunken eyes, edema anywhere, and are we having IV lines in situ? Okay, then we need to make the determination whether this patient is very sick or not severely sick. Also, we want to know if this patient will require assistance or not. Is this patient disabled or not? Okay. Is this patient for outpatient or not for outpatient treatment? If not for outpatient treatment, it means we are going to hospitalize. So we'll make that determination, then move on. Still on treatment, we want to know if we are dealing with a situation with good prognosis or not. Those with good prognosis will include the situation without neurological deficit, or at least minimal neurological deficit if at all. The cancer that's associated, whether it can be treated or not, but the one with good prognosis will have cancer that is treatable. So in summary, the situation with good prognosis will include no neurological deficit, minimal neurological deficit if at all, and the cancer involved could be treated. The poor prognosis will include many neural deficits, and the underlying cancer can't be treated. And also encephalopathy will have set in. When we find all this, then the prognosis is bad. There will be pain, and there will be no story but give analgesics. Cranial neuropathies will require radiation. If there is increased intracranial pressure, radiculopathy, or headache, give corticosteroids. If this patient is down with seizures, give anticonvulsants. If you are dealing with hydrocephalus with headache and encephalopathy and incontinence here, then embark on VPS, that is ventriculoperitoneal shunt. Still on treatment, if there's fatigue with depression, give modafinil or methylphenidate. If there's increased intracranial pressure, give dexamethasone or embark on ventriculoperitoneal shunt. To monitor response, you can have CSF analysis or fluorescence in situ hybridization, or you assay CA125, CEA, 5-HIAA, and physical examination. Still on treatment, focal radiotherapy is better than craniospinal radiotherapy. Lumbosacral spine radiation will be helpful for lower limb weakness with bowel or bladder dysfunction. You can administer leucovorin if the patient is on methotrexate. That will avert methotrexate toxicity or systemic effect of methotrexate. You can check my channel for leucovorin. I have made a full presentation on leucovorin and it's already published here. During treatment, you can make use of other medications like cytarabine, tautepa, intrathecal therapy, but we have to remove 7 to 10 minutes before installation. Glucopidase will be helpful, and capecitabine will not be out of place, but we'll get a better outcome if all these things are in the hands of oncologists and neurologists. And with that, I come to the end of this presentation. Remember to subscribe. Remember to share. I appreciate it.